Hello everyone, welcome to another video of Final MBBS Medicine MCQ discussions. In this video we are going to focus on adult polycystic kidney disease. We will look at the epidemiology, clinical presentation, extrarenal manifestations, evaluation and treatment. After going through these topics, we will look at few multiple choice questions to understand how these facts can be asked in your exam. Regarding the epidemiology, adult polycystic kidney disease occurs 1 in 1000 live births. It is autosomal dominant polycystic kidney disease. Polycystic kidney disease either could be autosomal dominant or autosomal recessive. There are many other variants. Autosomal dominant polycystic kidney disease occurs in adult patients. So it is called adult polycystic kidney disease. Autosomal recessive polycystic kidney disease occurs in children, so it is sometimes called infantile polycystic kidney disease. However, adult polycystic kidney disease is autosomal dominant. It occurs due to defect in chromosome 16 or chromosome 4. The gene located in the chromosome 16 is called PKD1 gene, polycystic kidney disease 1 gene, and the gene located in chromosome 4 is called PKD2 gene. Let's look at the clinical presentation of this condition. Usually it is asymptomatic. Therefore, if a family member is having adult polycystic kidney disease, it is important to screen the other family members as well. However, the consensus are controversial. The reason behind this is if we screen someone for a condition, then there should be a cure for that disease. However, for adult polycystic kidney disease, there is no cure. Therefore, the screening guidelines are a bit controversial. No age cutoffs have been given. However, by screening and early detecting these patients, we can prevent the complications. Therefore, screening has some place for this condition. And also, these patients can present with flank pain. What are the reasons for flank pain in patients with adult polycystic kidney disease? One is renal hemorrhage, which can cause flank pain. Renal calculi, which can be developed in these patients, can cause flank pain. And urinary tract infections. These patients are prone to develop recurrent urinary tract infections, so with that also they can develop flank pain. So flank pain is one presentation of these patients with adult polycystic kidney disease. They can also have hypertension. So we may diagnose adult polycystic kidney disease in the workup of hypertension. Usually this hypertension is found in the 4th decade of life. They can also present with abnormal urine. What are the abnormalities in urine they can present with? One is proteinuria. This proteinuria is mostly microalbuminuria, where they pass less than 300 milligrams of albumin per day. They also can present with hematuria, where there is blood in urine. Mostly it is painless, but it can be painful as well, because this hematuria occurs due to bleeding into the cysts which open into the pelvic axial system. So with that bleeding into the cyst, they can develop flank pain. And also, these patients may develop gross hematuria as well. So abnormal urine, including proteinuria and hematuria, are two presentations of adult polycystic kidney disease. They also progress to kidney function impairment, where we call it chronic kidney disease or CKD. The median age of presentation of CKD in patients with adult polycystic kidney disease depends on the gene which is defective in those patients. In patients with defective PKD1 gene, they present with 6th decade. Patients with PKD2 gene abnormality, they present usually in 8th decade. So kidney function impairment is another presentation. And also they may present with symptoms due to cysts in other organs. What are the other organs which can develop cysts simultaneously with adult polycystic kidney disease? The liver, pancreas, spleen and epididymis. So these organs can develop cysts with adult polycystic kidney disease. Those are the clinical presentations of this condition. And there are extrarenal manifestations as well. They can develop cerebral aneurysms, so they may develop intracranial hemorrhage. They may have hepatic and pancreatic cysts, cardiac valve disease, colonic diverticula, abdominal wall hernias, and seminal vesicle cysts. So these are some extrarenal manifestations. How we can evaluate a patient with adult polycystic kidney disease? We can do an ultrasound scan. Ultrasound scan is sufficient to diagnose or rule out adult polycystic kidney disease. We can diagnose adult polycystic kidney disease if there are 10 or more cysts measuring more than 5 mm in each kidney. And also in ultrasound scan the kidneys are enlarged and cystic in contour. Next we can do MRI as well. MRI is done if ultrasound scan is equivocal or if we need to evaluate a complication. What are the complications? Like if there is a kidney mass or complex cyst, for further evaluation we can do MRI. We can do CT for these patients as well. We can do CT with contrast if eGFR is more than 60 ml per minute per 1.73 square meter. If eGFR is less than 60, then we can do MRI. We can also perform genetic testing for these patients. However, these investigations are decided based on the index case. What are the treatments? As you know, if a patient is having adult polycystic kidney disease, we cannot reverse that condition. However, we can prevent the complications. If the patient develops CKD, then we have to do treatment of CKD. If the patient has hypertension due to this, then we can do hypertension management. The preferred medications are angiotensin converting enzyme inhibitors, ACE inhibitors like captopril, enalapril, or angiotensin receptor blockers like losartan, telmisartan, candesartan like drugs. And also we can do dietary modifications for the patient like sodium restriction. There's a new medication which has emerged to treat adult polycystic kidney disease, that is tolvaptan. Tolvaptan can be given for those with eGFR more than 25 and also for those with high risk of progression to CKD. So we discussed about the epidemiology, clinical presentation, extrarenal manifestations, evaluation and treatment of adult polycystic kidney disease. Now let's go through few multiple choice questions to understand this topic better. In this multiple choice question, we have to select which of these statements are true or false. So let's go through one by one. Regarding adult polycystic kidney disease, statement A mentions present as end stage kidney disease in third decade. You know this is false because they usually present with CKD in 6th decade in PKD1 gene abnormality patients. In patients with PKD2 gene abnormality, they usually present in 8th decade. So the statement A is false. B, it is an autosomal dominant inheritance. It is true. C, family members should be screened before 20 years of age. That is also false because there is no consensus like that. D, abdominal aortic aneurysm is a common presentation, which is false. It is not a common presentation of this. ACE inhibitors and ARBs are the mainstay of antihypertensive treatment. It is true. So the next question, it is also a multiple choice question. It asks, the following are causes of chronic kidney disease with normal size kidneys. So this question is about chronic kidney disease. You know that adult polycystic kidney disease is a cause of chronic kidney disease. However, in patients with polycystic kidney disease, autosomal dominant type, the kidneys are enlarged. Therefore, normal size kidneys are not there. So, answer D in this question is false. Later, in a future video regarding chronic kidney disease, we can discuss this whole question. But for the time being, you remember polycystic kidney disease for this question is false. The next question, what are the features of polycystic kidney disease? Answer A, increase in hematocrit. During the discussion, we didn't go through anything like this, but some researchers have found increased hematocrit in patients with polycystic kidney disease. However, it is not a proven fact. There are some controversial researchers as well. So, answer A here is false. B, nephrotic range proteinuria. It is also false because patients with adult polycystic kidney disease may have proteinuria, but it is usually not nephrotic range. It is usually microalbuminuria. C, hematuria, yes, it can be a feature of polycystic kidney disease. Pancreatic cysts is also true, and intracranial aneurysms are also true. Let's go through the other question. Autosomal dominant conditions. This question is also regarding the genetics. However, in the answers it says adult onset polycystic kidney disease. Now you know that it is true. The next question, adult polycystic kidney disease, we have to select whether these answers are true or false. Answer A, autosomal dominant, it is true. Answer B, can be associated with SAH. You know that adult polycystic kidney disease, the patients may have cerebral aneurysms as well. The rupture of those aneurysms may cause subarachnoid hemorrhage. So, answer B is true. Asymptomatic liver cysts can be seen. You know that liver cysts can be formed in adult polycystic kidney disease and they can be asymptomatic. So, C is true. Cause CRF. CRF is chronic renal failure. It is a synonym for chronic kidney disease. So, D is true. Causes painless hematuria. Yes, it is true. Another question. Recognize features of adult polycystic kidney disease. Liver cysts, true. Recent UTI, I think this may be recurrent UTI, so B is also true. Subarachnoid hemorrhage, yes, it is true. Painless hematuria, true. Autosomal recessive is false, it is autosomal dominant. Like that, questions can be asked in your exam regarding adult polycystic kidney disease. So go through this video again and refresh your memory. With this knowledge, you can answer any question which is asked in your exam.